My name is Rod Knight. I'm on the board of directors for the CBRC. I'm also a research scientist at the BC Centre on Substance Use, and I'm happy to be moderating the session today. First up, we have Ronita Nath from the BC Centre for Disease Control. Ronita is a research coordinator at the BC CDC. Her research focuses on the health of gay, bisexual, and other men who have sex with men. She's currently involved in community-based syphilis research as well as HPV and anal cancer research, and her expertise is in qualitative and mixed methods research. So we're going to give each presenter 20 minutes, 15 to 20 minutes, and we're going to save questions until the end, and we'll answer as a panel. So Ronita, I'll turn it over to you.
Hello everyone, my name is Ronita and I work at the BC Centre for Disease Control as mentioned. What I'll be talking about today is a study that we're doing at the BC CDC that's investigating the drivers of the syphilis epidemic in BC among gay, bisexual, and other men who have sex with men. This is a 3-year Vancouver-based mixed method study that's being funded by the Vancouver Foundation, and I'm presenting these findings today on behalf of a larger research team that includes Troy Brennan, Robin Perry, Jason Wong, and Daniel Grace. And before I get into the details of the study, I just wanted to provide some context on syphilis. So as you may know, Canada is in the midst of a syphilis epidemic, meaning that rates of syphilis are higher than would be expected. In BC, syphilis is at record high rates, and nearly 90% of cases are seen in gay, bisexual, and other men who have sex with men. Syphilis is a bacterial sexually transmitted infection, or STI, that can cause an array of symptoms from sores and rashes to neurological symptoms. Some people don't even present with any symptoms. Having syphilis increases the risk of getting HIV, and it also places those who are living with HIV at greater risk for complications and more severe disease. And so even though we're observing this rise in syphilis cases, we actually can't conclusively say why that's the case. And that was really the impetus for doing this study. So the study has 2 objectives. Firstly, to examine the knowledge, attitudes, and beliefs of gay, bisexual, and other men who have sex with men around sexual behaviors to better understand the drivers of syphilis infection and reinfection. And secondly, to examine broader systemic barriers to seeking testing, treatment, and prevention tools for syphilis and other STIs. We aimed to meet these objectives by doing a mixed method study, which has 2 parts. So the first part was a qualitative study, which consisted of in-depth interviews with 25 participants. And this part was recently completed. The findings from the qualitative study are now being used to inform the design of a quantitative survey that will be implemented later with a much larger sample. So today I wanted to share with you some of the findings from the qualitative study, which we completed a few months ago. Briefly first, to go over the methods for the qualitative study, all of the participants were recruited from the BC CDC clinics and through the online apps Scruff and Squirt. To be eligible to participate in the study, individuals, they had to identify as male, be at least 18 years old, identify as gay, bisexual, or other MSM. They must have been fluent in English and sexually active in the last 6 months. In the interviews, we covered a wide range of topics. So we talked about knowledge, attitudes, and beliefs around syphilis and other STIs. We talked about perceptions of STI risk, measures taken to prevent STIs, the role of substance use in sexual activity and decision-making, the acceptability of a pre-exposure prophylaxis or PrEP for syphilis and other STIs, and we talked about the role of social networks in these men's lives. So these were the characteristics of our sample. So we interviewed 25 participants. As you can see, the majority, 64%, were white, 76% identified as gay, 8 participants were living with HIV, 9 had had a syphilis diagnosis in the past year, and 13 had a gonorrhea or chlamydia diagnosis in the past year. Okay, so upon analyzing the data from the interviews, what quickly became apparent was that there were a lot of inconsistencies in the participants' narratives. Specifically, we identified 4 major inconsistencies. So there was this inconsistency between participants' self-report of their STI knowledge versus their behavior. We noticed an inconsistency between how participants reported their sexual behaviors to be in general versus how they reported their behaviors to be in very specific instances. We noticed that there was a discrepancy between what participants perceived their health risks to be in relation to certain behaviors versus the risk they felt those same behaviors carried when they didn't attribute those behaviors to themselves. And then we noticed there were inconsistencies in men's concern for syphilis. And I'll go through each of these. So first, the discrepancy between knowledge and behavior. Many of the participants reported that they were very knowledgeable about sexual health and STIs, and we saw this across serostatus. However, despite these reports, participants also described engaging in behaviors like condomless anal sex and sex with strangers. So as an example, we have a participant here who expressed being very knowledgeable about STIs, but he also described having sex with strangers, and he said, there's no socializing as far as we go for drinks or any of that. It's 2 people finding themselves, satisfying the need, and then getting on and going on with your life. Again, impersonal sex with a stranger is a huge turn-on. Another example of the discrepancy between knowledge and behavior was that in men's narratives, knowledge of the rise of STIs in BC was not attributed to changes in sexual behavior. For example, a participant said to us, I'd say it probably doesn't affect that. And he's talking about the syphilis epidemic impacting his sex life. Like I said, I have some concern about it, but if I'm looking to have sex with somebody, it's not something that I'm thinking or worrying about at that time. Now, when we tried to get behind the reasons for these behaviors, we received 2 general types of responses. So generally, among participants who did not have HIV or a recent STI, they expressed that these behaviors were spontaneous, and it wasn't like they wanted to have risky sex. It happened. As one participant said to us, it's always been in the heat of the moment. It's been passionate. Latinos were sort of known for that a little bit. Not to say that that's an excuse or that it should be okay, but it's happened. It was really intense. And yeah, I was an idiot. I take full responsibility. And it's happened. Many of these participants also shared this deep sense of shame and regret after participating in these behaviors. One participant said to us, that's every time I hook up with that one guy, I really don't know. I always feel really guilty and kind of grossed out, and I feel like I need to get tested just to be sure. Now, the narrative among those living with HIV or diagnosed with a recent STI was a bit different. Many expressed that these more riskier behaviors were intentional. Some said they were more inclined to participate in these behaviors because of the health challenges they had encountered. For example, one participant who was living with HIV said, I guess personally, having gone through the stigmatization of being HIV positive, I feel like I deserve to have sex without condoms. And that's okay for me to make that choice at this point in my life. It feels a bit outlaw on my part, and I think maybe that's not what a public health officer might want to necessarily hear, but that's how I feel. Okay. So going on to the second discrepancy, which sort of talks about this tension between self-reports of behavior in general versus self-reports of behavior in specific instances. So generally, participants reported that they engaged in safe sexual practices. However, in the analysis, we found that these perceptions didn't really correlate with descriptions of some of their behaviors. So for example, there were a few participants who said they used condoms, they preferred using them, but when we asked them about their recent sexual experiences, most had not used condoms. So as an example, the participant here said he used condoms, everyone should use them, But when we asked him about his last sexual experience, he said the following. That was that boo-boo I made. What would I say? I was with somebody who was more experienced than I was, and yet he didn't tell me that I should. I was older. It's not that I didn't know to use a condom. I knew perfectly well. It's just that in the moment, it was like, what? How did that happen? It's totally out of control. It's a sight not being trained. In the excitement of the moment, you just don't think. Now, honesty was also a prevalent theme in the interviews in terms of HIV and STI disclosure, and we noticed this same discrepancy in this theme as well. So participants expressed that honesty was very important to them. Yet again, they shared instances where they had not been entirely honest about their status with their partners. This is a participant who spoke to us about how important honesty was to him, and he said, honesty is important, like honesty and transparency about what kind of sexual behavior my partner's been engaging in. Like I said before, I feel harm reduction is my best strategy for my lifestyle, I guess. So if people have been having unsafe sex, I'd rather know and make an informed decision. So I think safe sex is a very broad term for me. It's more to do with conversations than it is to do with actual tools like condoms or gloves or dental dams. Now, the same participant later shared with us that he's not entirely honest about his status with his partners. And he said, I've had herpes for about 10 years. So that's also something I don't ever disclose when I'm hooking up with people because I take Valtrex, and I haven't had an outbreak for years and years and years. Okay, so the third discrepancy talks about the tension between self-perceived risk and likely risk. So generally, participants associated their sexual activities with very low risk. But then again, they felt those same risks, those same activities carried a lot of risk when they didn't attribute those activities to themselves. So for example, one of the sub-themes from the analysis was the sentiment that it was less risky to have sex with one's sex buddies than it was to have sex with strangers. And again, we saw this across serostatus. Several participants had partners they would hook up with occasionally, and they referred to them as their sex buddy or some other similar term. The idea was that sex was considered riskier with strangers because you didn't know their sexual health history or status. But when we asked participants how much did they know about their sex buddies, they actually said to us not much, but it was more a matter of trust. They trusted their partners would tell them if something concerning came up with their health. So for example, this is one participant who said, with someone that I don't know, I would not have unprotected sex. But with my regular contacts that I've known for years now, I'm more comfortable doing that. I feel like they would be honest with me if there was an issue. These participants also shared with us that their sex buddies were having sex with other people, but they did not know who these other people were or the nature of the acts taking place between them. And when they reflected on that, they shared with us that, yes, I guess it could be entirely possible that sex with my sex buddy could be equally as risky as sex with strangers, but they just perceived it to be less risky. This is another example of the discrepancy between self-perceived risk and likely risk. When participants discussed their last condomless experience with us, most did not feel that the encounter was at all risky. Yet, when we asked participants what they thought risky sex was, the #1 response we received was condomless sex. Here's an example of a participant, and he did not feel his last condomless experience was risky, where he did not know his partner's status. When we asked him what he thought risky sex was, or what he felt risky sex was, he said risky sex is not using a condom when not knowing someone's status. Yeah, so risky sex would have to be bareback or condomless sex with someone who you were not 100% confident that their status was negative. And that would be like them showing it to you, them telling you their status, and you knowing that person well enough to know that that is legit and you can trust them. And the last example I have of this discrepancy involves alcohol and drugs. Now, most of the participants acknowledged that alcohol or drugs played a role in their last condomless experience. They shared that it affected their judgment about sex and it made sex riskier. Some of the narratives we heard on this topic were, when I drink, or usually when I drink, I'll do coke and I'll go on Grindr and find somebody, and then I'll regret it the next day. Another participant shared with us, "I've never been sober at the bathhouse. I mean, yeah, when you're drunk, it doesn't really bear explaining. It feels like it's easier to make decisions. It decreases your sense of caution." Now, what was interesting to note is that while participants shared with us that alcohol or drugs made sex riskier for them, many did not consider their last sexual experience involving alcohol or drugs risky. And finally, we have the last discrepancy, which talks about the concern for syphilis. So many of the participants expressed that they definitely did not want to get syphilis. It was very important that they not get syphilis. But from the same participants, we also heard some narratives that were a bit to the contrary. So for instance, this participant here said he did not want to get syphilis. Very important to him for him to not get it. In some follow-up questions, though, when we asked him how concerned he was about it, he said if it was the 16 or 1700s, maybe syphilis would be concerning. It's probably less of a concern now. I think it's a course of antibiotics or something like that. But it's probably something that you don't want to get, like anything, right? If you can help it. Another participant who also said, definitely doesn't want to get syphilis, said, "I'm not concerned. I don't care. It's like a cold. You take a couple of pills and it's gone." And this conception that syphilis was very easy to treat was actually a very common conception among many participants who had not had syphilis. Others felt that while they did not want to get syphilis, they believed it was hard to prevent considering their lifestyle. Overall, we found that HIV was a foremost concern to participants, and the other STIs were not really considered. Okay, so what can we take away from these findings? Well, firstly, the high-risk behaviors described by many of the participants may actually suggest low STI literacy, despite what participants said about being very knowledgeable about sexual health and STIs. The findings do indicate several potential drivers of the syphilis epidemic, such as low STI literacy, as I mentioned, low self-perceived sexual health risk, high-risk behaviors, including unprotected sex, lack of, HIV and STI disclosure, sex under the influence of alcohol and drugs. And compounding all of these issues is that concern for syphilis is very, very low among the group. Overall, though, I have to say it was difficult to determine the drivers of syphilis in the study due to the contradictory narratives that emerged regarding knowledge, behavior, and perceived risk. However, such discrepancies have been found in other studies, so it's not unusual. Assessment of one's own sexual risk tends to be largely subjective and actually quite poor. A limitation of the qualitative nature of the study was really its ability to accurately assess health literacy among the participants. So low health literacy is associated with poor health outcomes and poor use of healthcare services. And the questions we had about sexual health knowledge received very vague answers, no matter how much we probed, which at the end of the day made it very unclear how knowledgeable the participants actually were about sexual health and STIs. Like they could say, I know everything about it, but we weren't trying to test them on it. That wasn't the point of the qualitative study. So a quantitative study would probably be better in accurately evaluating health literacy among the group. And it's very important to note that these qualitative findings by any means cannot be generalized to all gay, bisexual, or other men who have sex with men, or to everyone in that group in Vancouver. A quantitative study with a larger sample is really necessary to make those kinds of generalizations, and that wasn't really the point of the study. So at the end of the day, a quantitative survey is needed, and the good thing is we are in the process of designing that survey using findings from this qualitative study to help us formulate those questions that we need answers to. And that's it.